Thank you very much, William, for setting the tone of the day. And I'm now really looking forward to our next panel that is, will follow in the same direction as started with our keynote lecture. And it's called, the theme is Healthcare Worker Wellbeing and Safety, and session entitled How the Fatigue and Wellbeing of Healthcare Professionals Interact with the Uptake and Implementation of Technologies. And first of all, let me introduce the moderator of this session, who is Peter Walsh, that, as I already mentioned, we met last year for the first time, where we got the invitation from Peter to write the article about our conference. That was about the times of crisis, how to keep patient safety at the top of the agenda. And we thought, okay, yes, that's very interesting. And we wrote the article, we published it. And as we were really happy about the outcome, we did it again this year. And then we thought, well, now it's time to meet in person. And Peter kindly accepted to be the moderator of our panel today. Your floor.
Thank you very much, Mirka, and good morning, everyone. It's a pleasure to be here. As Mirka said, one of the hats I wear is as an associate editor of the Journal of Patient Safety and Risk Management. And I do commend the article that's in your pack that gives a good background to the topic of today's conversations. I've also spent the last 25 years as an advocate for patient safety, mainly from a patient perspective. And this year, in fact, I had a salutary lesson about the challenges faced to staff when my wife was admitted as an emergency admission to a hospital near me in London. And seeing, because it was so busy, she was next to the workstations that the doctors and nurses were using, and she heard the conversations and saw the stress, the fatigue, and the frustration that those staff had in trying to deliver good quality care. And some of it was not helped by how the technology happened to be working at that place on that day. From a patient perspective, nothing's more important to helping ensure safety than the well-being of our staff who are going to look after us. And I approach the whole subject of digitalization, use of increased technology, both with excitement for the huge benefits that lay in store, but also with a good degree of trepidation based on my own personal struggles with technology and my seeing it in practice. But we have a distinguished panel with us here today to help us through this topic. We're also going to make sure there's time for you to ask questions. So I think I'm going to need to, the slides are being moved for me, so that's great. I'll start off with introducing my panel. And first of all, I'd like to introduce Alvaro, Dr. Alvaro Cerame, who's president of the European Junior Doctors Association. And we have Professor Marta Macías from SECA, the Spanish Nurses Association. Thank you very much for being with us. We have Professor Reinhard Strametz from the Wiesbaden Institute for Healthcare Economics and Patient Safety. You've just heard an amazing presentation setting the scene by William Monahan. Thank you for that, William. I won't say any more because he's made it very clear what his role is and how much he knows about this important topic. And lastly, but not least, Pedro Vieira dos Santos from Medtronic, who's also a vice chairman of the European Patient Safety Forum. Now, I said we want to make this as interactive as possible. We're also going to have our own go, with great trepidation, on using technology ourselves. So, if you scan the QR code that you can see on the screen with your device, you will be able to answer these questions about digital health applications. So we'd really like your feedback. I think that stays there if we go on. So you see that there are a number of questions that we'll be touching on, but we want to hear what you think about them as well. And we'll be showing the results of this at the end of this presentation. Okay. I'll leave that on. Okay. There's lots of things coming on. Okay, well, you can watch it live whilst it's happening, or maybe I'll come back to that, and then we'll go and look at the results at the end. Is that okay? All right. Okay, with no more to do, I'm going to ask each one of the panel to give their views on what they perceive as being the biggest opportunities, but also the biggest risks for patient safety, bearing in mind as well the impact on staff, well-being, fatigue. And we're going to start off with Alvaro. Over to you, Alvaro.
Thank you very much. Well, first of all, thank you to the European Patient Safety Foundation for inviting us, and I think it's really valuable to have the voice of junior doctors because, I mean, having boots on the ground, and especially the professionals that have just started in the workplace and in healthcare context, I think it creates a valuable contribution. So I think that speaks volumes of European Patient Safety Foundation. Probably before answering the question that we are intended to ask, I think it's important, probably all of you know that the context of the healthcare workers right now in Europe, but also in the world, it's very dire. So as one of the OECD reports put it, the health workforce is overworked, undervalued, and underpaid. And in the 2022 report by WHO Europe about the health workforce, in the words of the European Regional Director of WHO Europe, Hans Kluge, he said that the situation of the workforce was a ticking time bomb. That means that we need more healthcare workers. There is a lack of it, and that is unevenly distributed in different regions of Europe. But also we need to understand what is going on with the workforce. There is a report also commissioned by WHO, but in this case of the World WHO, that is called Our Duty of Care, and it highlighted some of the statistics around the workforce situation in terms of well-being. It displayed that the prevalence of burnout is estimated between 51% to 88% all over the world, with a more or less mean of 66%. And then there is a high prevalence of anxiety and depressive symptoms on the workforce. So probably that has something that has to do with COVID pandemic, but it's also something that we have seen that it has been happening for the last decades. And probably we could claim that it has to do with the complexity of healthcare systems, the technologies that have been introduced, the procedures, and the need of coordination and communication of the different agents that work in the healthcare system. So that has been going on. But we would argue, or from the perspective of my organization, is that the increasing complexity and the increased use of technology has taken place under a false, unquestionable premise, which is that workers' productivity has no limit. But probably based on the figures and facts that we were saying is that probably we have reached the threshold of productivity of workers. And right now the situation is that since we have reached that threshold, what we're seeing is that people are suffering from it in terms of an occupational phenomenon such as burnout, but also in terms of mental health problems and physical health problems. So what we would need to understand is how to ameliorate that burden in order to provide safer care. Because what we know that happens is that if burnout happens and there are other mental health conditions going on because of the workplace stressors, this is going to reduce the cognitive function and other reasoning processes that are needed for patient care. And we know that is one of the limiting factors for quality of care and patient safety. So the second idea I would like to propose, this was the first one, is that quality of care and patient safety paradigms need to be built upon the premise that one of the limiting factors, or one of the most important limiting factors, have to do with workforce needs and the situation of the workforce. We have been collaborating with the WHO Europe Office of Athens, which is quality of care and patient safety, and we have given feedback on the report that they're going to present in December about the situation of quality of care in Europe. And what we were encouraging them, and they have been encouraging us as well, is to work on workforce indicators that could reflect upon what quality of care and patient safety, not only the number of doctors and number of nurses. The last ideas, and then going back to the panel, which I think it's going to be very interesting to know the people's experiences, is that from the perspective of junior doctors all over Europe, there is a lack of training in the use and implementation of digital technologies. So there is a massive digital skill gap. So for example, one of the things that I did on a conference we had with junior doctor representatives all over Europe some weeks ago is to ask people, and I'm going to ask also to yourself in the room, like how many of you are directly involved right now in patient care? Could you raise your hands? Okay, so from those of you who are directly involved in patient care, how many of you use an electronic health record? Okay, so from those of you, how many of you have received training in how to use it? So 50%, 40%. Yep. So last time I asked this in a conference of European junior doctors, it was less than 20%. So I think this is like a very interesting number. The last idea I would like to present is that there is a disconnection, and I think probably William covered in all of this, so I'm not going to say anything else, between the developers of digital solutions and the users. I have a problem at my work. We use the electronic health record system that more or less half of the Spanish hospitals and primary care centers use. And I was talking to my boss and I said, I work in a consultation, I'm a psychiatrist. So normally I just have to see patients all over again. So when I'm going to do another, consultation for another person, I'm going to give them an appointment, I have to do like around 14 clicks. Because then I have to say, this is my agenda, I'm a psychiatrist, my name is Alvaro, this is the number of appointments I'm going to give, then click on the date, click on something else that if my profile was uploaded, I would save like 80% of those clicks. And in the end, if you take out the amount of seconds it takes, I calculated it, it's a working day per year. So I told it to my boss and I said, okay, write an email to the electronic health record system so that they can upload everybody's profiles on that. And they said it was not possible. So, well, I think that probably we would finish with the statement that William said, that I think we should start with the user needs. So, thank you very much.
Thank you, Alvaro. I forgot to say that we are going to have an old-fashioned opportunity to put your hand up and ask questions, as well as the Slido technological approach. So bear in mind that be thinking about a question you want to put to any one of our panelists when each one of them has had a chance to speak. So we've heard from junior doctors. Only fair that we now hear from the nurses. Marta, could you give us your perspectives, please?
Thank you. Yes. Good morning, everyone. First of all, I'd like to thank the organizer of this conference for inviting me here today. Thanks, Peter, for the presentation. I will talk in general about healthcare professionals, about how the technology impact in their work, but also about nursing. I will point out 5 main benefits of the technology. The first one will be improve patient outcomes. With the help of the advanced technology, nurses can better monitor and manage patient conditions and make informed decisions, resulting in faster recovery times and reduced hospital stays. The second one would be enhanced communication. Telehealth technologies have made it easier for nurses to communicate with patients and doctors remotely, providing timely care and reducing the need for in-person visits. The third one would be enhanced patient safety. As you know, technology can help reduce and prevent adverse events through features such as barcode scanning for medication safety and electronic healthcare records that provide real time across all healthcare settings. The fourth one would be improve workflow and documentation. Technology streamlines nursing workflow by automating routine tasks, which can reduce the administrative burden. And the last one of the benefits will be increased patient engagement. I think technology empowers patients to take an active role in patient safety by providing access to personal health records, health apps, and portal patients. But although there are a lot of benefits, technology also has its challenges. And I could highlight 6 main risks. The first one will be adverse events, although I said before it's good for increased patient safety. Although, besides, the use of technology could provoke some unanticipated consequences and produce adverse events. The second one would be resistance to change and adoption barriers, like the presentation before point out. Professionals may feel intimidated or need more confidence when using new technologies. The burden for the professionals will increase if the technological approaches are designed or implemented poorly. They will experience high levels of stress and burnout and may be less motivated to adopt new technologies. The third one will be reduce the human interaction because the over-reliance on technology produces that we focus on the screen and on the technology, and we forget that we have a patient in front of us. The fourth one would be technology blindness or overuse. The risk is to prioritize the use of technology instead of other measures such as revising a pathway or introducing a checklist routine. The fifth one will be increased reliance on technology might lead to loss of critical thinking skills. And the last one, integrating new technology with existing systems in our healthcare. And that's all. Thank you very much.
Thank you very much, Marta. Now, over to you, Reinhard. Oh, sorry. Yeah.
So, I'm an anesthesiologist by profession. I worked 8.5 years at a university hospital, putting patients to sleep every morning. So putting them in a potentially life-threatening condition, to be honest. I did that with pride and confidence, and also with quality, I think. I was then chief quality officer of a university hospital, being responsible for 6,300 employees and 13,000 people annually treated at our institution. And so I basically want to share two learnings I made in that position, because now I'm in a fortunate position of being professor. So in the morning I'm at the university, and in the afternoon I'm at home. So having the time to think about digital innovations. And so first thing is, what I learned from quality management, if the foundation is not solid, you should not think about the roof. So you should not think about AI if you have to log on in a computer longer than a waiter does in a restaurant. So if you go to a restaurant, see the electronic systems, ordering systems, they will log on within 2 or 3 seconds because time is money. And so if you cannot do that in a hospital, you should first do your homework and then think about AI. So because otherwise I think it will only create digital fatigue, not fatigue, increased fatigue, but create digital fatigue. Thinking that everyone is looking at TikTok movies and videos like a zombie on the mobile phone does not make us digitally literate. And so I have to deal with a lot of young students being 17, 18, 19 years old. Most of them are not digitally literate. So we have to invest in that kind of digital literacy. And I think we also have to change the medical education that, at least in Germany, still is stuck in the last millennium, not in the last decade. And the second one is that I think William perfectly pointed out that making digital innovations is not free of risks. So everything that is effective in medicine comes with risks, like medication, like a new medical device. And we have to consider that, put ourselves in the patient's shoes, or maybe put the person we love the most in the patient's shoes, and then think about what we do. And by being a chief quality officer, being responsible for continuous quality improvement, I learned that we have to acknowledge that we are still human beings. So the capacity of innovation and change in human beings is limited. And if we don't acknowledge that, we will ultimately fail with that. So my capacity of change, and I have a lot of time to think about AI and learning how to prompt and creating pictures for my lectures. So I have a lot of time, clinical doctors don't have, is still limited, and my capacity is still limited. And if we overstress the people, that will contribute to moral injury, and that will contribute to fatigue. So we have to acknowledge that the developments we can make are time critical, and they will take decades to unveil their full potential. And so we have to set the sails, and we have to go there with a decent speed, but we must not over-exaggerate that and must not stress out our people with digital innovations every day. So I think one of the responsibilities of healthcare leaders should also be to keep the people in the healthcare system away from too much innovation and set a decent pace that you can go in the right direction. Because yesterday when I flew from Frankfurt to Madrid, we accelerated the plane, and our first officer told us that the amount of energy needed for that plane would be equivalent to accelerate an elephant to 930 kilometers an hour. And as a doctor, I must say, I would not like to imagine that, because this ultimately would cause a lot of harm to the elephant. So if we accelerate our people too fast, then we will receive the opposite. So that's my 2 thoughts for the moment. Thank you very much.
Thank you very much, Reinhard. William, back over to you.
Thanks. I think you've heard quite enough from me for one day, but I'll be very short in my reflections. The first is I completely agree with your point around the relationship between clicks and fatigue. In my office, on my whiteboard, I have the words clicks cost lives. The more we can design that out, the more time we can give back to people. My final reflection is on the kind of question around training. And I think it is absolutely vital that we give people the digital skills to be able to use the systems. And it's important that we give them the right kind of training, which looks and feels like at elbow support when you are actually delivering care on the system. But it fundamentally matters how we design those systems. We don't train people on Facebook or Instagram, even though they're much easier systems to use, because you can use them intuitively. I don't know what the situation is like across Europe, but in the UK, if you need to park your car now anywhere, you have to download a plethora of parking apps to do it. And every time I get a new parking app, it takes me a couple of minutes, but eventually I get there and I understand how to do it. That's just not the case when we're asking people to use systems to deliver care. They're so clunky and unintuitive. One of the things I had the privilege of doing recently was going on a ward round through the acute medical unit, and under the supervision of junior doctors, do not worry, they allowed me to enter all of the details into the EPR that we are currently in the process of replacing as quickly as possible. And one of the things that I had to enter was the need for a urine sample test, and the machine asked me where the urine had come from. Had it come from the eyes? Had it come from the ears? And so our ability to design with context is absolutely critical.
Thank you very much, William. And finally, industry has such an important role to play in this, which is somewhat of an understatement.
We just need to fix all of this, right? So
it's down to you, Pedro.
My part now is we just need to,
Pedro.
to have it in
no
mind,
pressure.
Right? No, I think there is no doubt that in the last several decades, medical technology brought amazing innovation and amazing impact on our patients' safety. That's a given, right? But there are times where we need, as in the industry, to realize that we are not on the toy industry, right? We can't just be bringing new toys, because that's not meaningful innovation. What we really need to focus on bringing things to the market that are really a step forward into both patient safety, but also having in mind the user needs. And that's something that I think most of the industry players have been focusing most in the last several years, is what are the user needs and how we can put it in place. But we still see a lot of new vital signs that don't really bring that much, but it's like consumer goods, right? You go to your supermarket and you have a plethora of detergents that are all the same, but they are marketing in different ways. So we need to be careful as industry, not just to be launching things for the sake of marketing, but really launching products that are bringing innovation that will impact the system as a whole, not just the patients. Because, and we have heard several different examples, our healthcare professionals are in a very difficult moment. And we need to be a part of the solution for that, not a part of the problem by bringing things that need more clicks, more monitors, more screens, but actually on the opposite side. How can we help improve workflows? How can we help, honestly, taking patients out of the hospital sooner rather than later, making sure that their patient safety is still absolutely guaranteed, maybe even more than before, but reducing the workload that the hospitals, as an example, are suffering. So this is what the industry needs to be doing, is working together with healthcare professionals, working together more and more with the patients themselves, because they are getting more and more aware of the importance they have in the system. And with that in conjunction, making sure that what we are bringing is meaningful innovation. Then we have the training piece. Oh, here you have a product. No, that's not the way it works. Healthcare doesn't work like that. We need to train deeply how those products are being used and why they are being used. Because we were talking about resistance to change. Of course, in the situation the workforce is right now, of course they are resistant to change. So you need to be very clear on why you are implementing that change and what are the benefits for the patients and what are the benefits for themselves as well. So the training education piece is fundamental along with the implementation. And by the way, you are invited for the workshop on implementation in the afternoon. But the industry has, and when I talk about industry, it's the entire industry that is touching patients, right? It's not just medical devices, not just pharma, not IT, which is getting even a bigger part of importance now, is all the players need to be focusing on bringing meaningful innovation, implement it correctly with the proper training education, and trying to beat that resistance to change. Thank you.
Thank you very much. Well, that's a really fascinating set of perspectives from different constituencies, if you like. I'll just throw in one extra one, I think, because it's been so well covered, is how much it helps for things to be standardized. For one hospital be using the same system as another hospital, for different regions to be using the same systems, as opposed to nurses or doctors, when they move to a different place, it being a completely different IT system, it being a different product, et cetera, et cetera. And it just strikes me that countries with national health systems have a unique opportunity to get that symmetry, to make things as joined up and as similar as possible right across the system. That's enough from us for the time being. I did warn you I was going to ask for hands up for questions from any of you, and there's one just here. I think we'll... Okay, we've got a roving mic on its way to you.
Thank you. Thank you very much for the presentation. I'm José Ferrer from Badalona, Asistencial in Spain. I'm a family doctor, GP. I've been working for 20 years as a GP, or 23 now. And in this time, I've worked with 3 different systems in the daily practice. Yeah. And every time it's been a burden to learn by ourselves because we had no formation for that, no education for that. So my question, I think it's more for Mr. Monaghan, because you're doing a great work in getting closer to the final users. And of course, we've been misusing technology for a long time, and I think it's time to have a positive digital transformation now that could allow us to rehumanize the medicine, the healthcare, because of that technology and this misuse, we have lost a lot of the human contact with the patient. We have now this common enemy in the practice that is the keyboard, is the common enemy between the patient and the doctors. I see some of my colleagues all the time doing like this in the keyboard, and they don't even look at the patient. So I would like to know what are the lessons you've learned with this approach to get closer to the healthcare providers on how to use technology in a better way.
Thank you for that question. So I think what we've learned, I guess, is the first part of the question, is that the way we build, design, and deploy technology has fundamentally been wrong for the last 10 years, 15 years. And we're trying to start a bit of a movement around stepping back and letting clinicians step forward. Nobody understands kind of the pain and the opportunities that technology brings, quite like our clinical colleagues. So the more we give them time and space to do this work, the better the outcomes that we are getting. It's also helping us to the point around kind of step forwards in innovation. It's also helping us to think about what are the right steps forward in innovation for us to take. So a really good example of the scenario that you've described that we've started to look at is the use of ambient AI. I don't know if you're familiar with it, but essentially it's a tool that is listening to the interaction between the patient and the clinician, and it's identifying when the patient is speaking and when the clinician is speaking, and provides a summary of the conversation at the end and allows the clinician to confirm the decisions that the AI thinks the clinician has made as part of it. Now, my initial view when I saw that is this is going to be brilliant. Every clinician will love it, and we can use it immediately. But which is probably where we would have ended up if I was in charge of everything, which I'm definitely not. But what we actually found was that clinicians liked aspects of it, but they liked the bits that were taking away the documentation burden, and they liked the ability to capture the record and to not have the gap between the keyboard and the patient. But what they missed when we were trialing the technology was the process of thinking through the consultation afterwards and actually drafting or dictating the letter, which I thought would be the bit that they wanted to get rid of, but actually kind of that was the bit they were most interested in keeping hold of. And so I guess it's an example of how if we can use this emerging technology to bridge some of that gap that our clinicians are feeling, but absolutely keep them in the driving seat of the decision-making and how we do the implementation.
Thank you, William, for that. Are there any other questions from the audience or observations? Yes, we have someone with a hand up there.
Thank you. Dave Whitaker, European Board of Anesthesiology. Great session, fantastic topic. Anaesthetist told, start with the user needs, was told to the UK Health Minister personally 25 years ago before they wasted 20 billion on the IT system. The latest IT scandal in the UK is the Post Office, where staff have committed suicide, again very expensive as well. And in Wales, 3 nurses were sacked for not supposedly having kept computer records of a deteriorating patient. And then 4 years later, somebody went into the computer system and found out that somebody servicing it before that had deleted those nurses' records. So my question is, what safeguards for the staff are being built into these systems when you're incorporating them into hospitals?
Okay. I think this is one for all the panel, really. Who would like to respond to that first?
I can start. From an industry perspective, IT security has become a crucial point, because whatever we want to put out there needs to be taking care of all GDPR pieces, but also the IT safety part. Cybersecurity is becoming more and more important. So are we doing all the things we should? I would say probably not yet, but we are trying as much as possible. And there will be always more things to do once we solve those. But we try to put everything, but there is always the human piece that we are very creative as humans, so there is always a way to get there. But as an industry, everyone is investing significantly on trying to make sure that those kind of situations will not be able to happen.
Okay, thanks. So I have 2 views on this. So the first is, I think it's really important that as you build systems, you build in transparency by design. And I think we are starting to see there's a bill going through Parliament at the moment which sets out a minimum requirement across all healthcare technology suppliers that has transparency built in, learning some of the lessons from the post office, but remains a real worry to me personally. The other thing that remains a real worry to me personally is if you want to be the chief medical officer of a hospital, you have to be able to demonstrate not only credibility with your colleagues, but also your qualifications relevant to that job and your professional registration. If you want to be the chief nurse of a hospital trust, you have to be able to do the same. To do my job, you have to be able to convince 4 or 5 people on a panel that you can do the job. That is no longer an acceptable situation as we embed technology into healthcare. Many of us are voluntarily on a professional register. We have to make the jump to making that a requirement across Europe for everybody doing this kind of job.
Thank you. Oh, you could.
Yeah, just a short remark from the perspective of risk management. So you heard and you read that I come from Germany, and in Germany we have a big issue with data protection. But the biggest threat to patient safety, from my point of view, is not the loss of data or the publication of patient safety data, but it's the loss of integrity of data. So if the integrity of data gets lost, like medical records being deleted or even pictures being manipulated, then patient safety is really at risk. So, and I think, as far as I know, most of the people in clinical risk management, they are still afraid that some data will go public or will be sold in the darknet, which is of course a problem. But I think we also have to bear in mind that the loss of integrity of data would be a much more bigger catastrophe, and I think we are not doing enough to ensuring the integrity of data at the institutional and the organizational levels. Thank you.
I think it's a crucial point, and the documentation, the health records must be safe, must be secure for patients. In Spain or in our community, there is a traceability system. So if you try to delete or to change something in the medical records, you can see what professional do that. So I think there will be some gap, but I think it's a crucial point to work, and we have to be very sure that it's safe. Thank you.
Could I add something? I have the microphone.
Okay.
Yeah, like probably what you mentioned highlights several aspects. So from the more boots on the ground situation of how the IT systems are implemented and the safe mechanisms, I think the point about the integrity of data is like vital. But if we go a little bit upwards, we find ourselves in a situation in which we will have to implement within the context of the European health data space. I mean, systems which are compliant not only with the GDPR, which is vital for many, as you may already know, like concerns, but also because, I mean, there are different uses of data. You will have the primary use for clinical data, which needs to be protected with many layers, because obviously clinical data is really highly sensitive data. And if a data breach were to occur, I mean, that could be potentially catastrophic for many individuals. And that is something which is probably going to be one of the key aspects that we need to focus on, this kind of security for health data, especially if we are going to implement interoperable and everybody is going to have an electronic health record system. Because the second point I would like to make is that we are coming from the perspective that everybody has an electronic health record system, but that's not the case everywhere in Europe. I mean, only last year, one of the biggest hospitals in Madrid, they used electronic health records for some parts of the hospital, but not for the whole of the hospital. So you should see the chaos it created when they tried to implement a unified electronic health record in a hospital that employs, I don't know, thousands of workers. And also, in relation to the European health data space regulations, then I will get to secondary data if we have time, is that there are countries that have NHS-like systems, or they have like big regional systems. In those cases, it could be easier to develop technologies that are compliant not only with GDPR, but also with the European health data space regulations. But if we find that there are countries, which could be like the instance like Central European countries, that are also based on individual consultations or group or clusters of professionals that have like small practices, probably they are not going to have enough resources to have these kind of compliance systems. So if the states do not invest in these kind of technologies which are compliant with their own regulations, they're probably going to create very like issues for those professionals, and then probably that there are going to be other like actors that are going to then try to provide those kind of solutions. So that could also create some kind of conflict of interest, which leads me to the last point, and I'm going to be really fast, which is secondary use of data. So it's vital for research purposes and many other advances in clinical and scientific research that we can use data for, like, I don't know, developing new technologies, drugs, and so forth. But we need to be careful with how those data are managed, with all the concerns about the privacy of individuals, and also like the, as I was saying, conflicts of interest that might appear. So I think that question could highlight many other aspects that are underlying the use of electronic health records and the use of data in a world in which data is as valuable as it is.
Thank you. We've got time for 2 more questions. There's a person with their hand up there, and then Vanilla.
Is this working? Yeah. David Borshoff, private anaesthesiologist, Perth in Western Australia. I find it hard to get excited about AI in medicine, and as William pointed out, when you have difficulty logging into computers. And I just want to emphasize that we have all of this exciting technology available, and many of us who are in that little niche can see the potential, but the foundations are what really has to be focused on in many healthcare systems, particularly where I come from. And I was thinking that it's not all doom and gloom. I just want to cite one example. We've introduced the Pyxis medication system in our hospital, which I was initially skeptical about. And I can walk into my operating theatre, put in my number and put my fingerprint on it, and I have access. And it's that aspect, it's a simple thing, and I know it's a very minor part of what we're talking about, but it's that simplicity that actually speeds up my day. I'm not waiting in line to sign drugs out of a cupboard with nursing staff. So I'm just citing an example where it can actually work and increase productivity. And the second part of my question was that, and this is probably relevant given what we've just been discussing, having been involved in sort of app development and trying to deal with or negotiate with or liaise with industry, the concept of security of data and transfer of data and knowing how to do that effectively and efficiently always seem to come across roadblocks. You know, we're all into this two-factor authentication now. Whenever we get onto our computer, it takes a few more clicks to get where we want to go. And the point I want to make is, doesn't that work against us if we're trying to innovate and try and develop technology in healthcare?
Thank you. Pedro, and we'll come to Reinhard.
I can just start with the first part of the AI buzz, and everyone is excited about AI. I think we should, because it's super interesting. But you need the base to be very strong, right? Otherwise, we go back to my comment on the toy industry, right? Because everyone wants to start playing with AI without having everything else solved on the basics. So you are just adding more noise and more confusion to the system. So that's a danger, that's a risk of jumping in. But we want to jump in because there are so many good things that can come out of the proper use of AI. And by the way, AI is around for the last 60 years. We have plenty of products in the market that have been using AI for many, many years. So is the buzz about what we have been having with ChatGPT and Copilot and so on in the last 2 years now. By the way, it's just 2 years in December. But the basics needs to be there. I fully agree with that, because otherwise it may be more damaging, and probably William can be talking about that even better. It can be more damaging than something actually useful.
Yeah, so I would add that I think innovation is the natural enemy of routine and also the natural enemy of safety and security, which is not a problem, but it's only two sides of the medal. So as we are not in the toy industry, but in medicine, we cannot use anything that's possible when building up a PowerPoint presentation, for example. And as long as we acknowledge that, and as we stand the conflict that arises from that, and I've seen a lot of ambitious, young, very naive people trying to design an app for clinical reasoning in the emergency department. It's a two-people company with no budget, and I wanted to make an algorithm for treating patients. And I just said, well, please do something else. Play in a different sector, and then maybe if you are a billionaire and have hundreds of people, then go to the emergency department and develop an app. So I think we have to be very clear that not everything that's possible is useful in medicine, and especially in acute medicine. And as long as we fight the battle between the security and the innovation part, and it's always a battle, as long as we are living, as long as medicine is existing, then we are right. But it's I think, the most complex industry in the world, medical industry. And so maybe it's good not to start with some of the innovation in that part, but also do the basics. And if you can log in a system in 2 seconds, that's a huge benefit for doctors and clinicians. If we could achieve that European-wide, that every doctor and nurse can log in into the electronic health system within 2 seconds, that would be a big advantage, and that would increase patient safety dramatically. Thank you.
Yes, I mean, AI, getting into AI is complicated, and probably there are many nuances, but I think that several of the points that were made are really interesting and vital to understand. So I would say, or we would argue, that the history of medicine is the history of the implementation of technologies. So AI is just one of the technologies that we have decided to implement or not to implement all over history. And probably we would have many things to learn about how we have implemented previous technologies and the risk assessments and the ethical underpinnings of what it means to implement a technology for what purpose also. Because I would say that probably, and the example you were putting before about the ambient AI, what's it called? Yeah. So if it's useful for reducing bureaucratic loads and so forth, probably it's going to be really vital. But the problem is when we are trying to implement it in terms of clinical reasoning and clinical decision-making processes. So we would also need to understand that from a medical epistemology perspective, our clinical decision-making processes are also sometimes a black box process. So we don't know exactly how they work. We have some like ideas and it is useful, and we have tried it for hundreds of years, and it has worked with like enough levels of security and safety. But the problem of using another black box model that we don't know exactly how it works could also create this illusion of being efficient and illusion of thinking you have the clinical competency, but then if junior doctors or the new generation start using technologies of clinical decision-making processes, this could be one of the potentially very challenging aspects. So I think that in this part, I would like to highlight those aspects.
Thank you. Was there another question? Yes, time for one more.
Thank you so much. If we think of all this from a policy perspective, from the European Union, it's all about the European health data space. We have regulations coming, and I mean, every country, every member states need to take that into consideration. And it's also a system coming that will, I don't remember the exact name, but something, My eHealth, you will have a summary of your patient record in your phone, which also will be automatically translated to a language where you are or seeking help in healthcare, not only for accidents, which has been so far a legal right for EU citizens, but also for other types of care. And of course, that is a real advantage for people who are traveling or working in other countries, I mean, to have that kind of help. So I just want to also raise some kind of, positive approach also about this for people, patients who are really not that literate all the time, also about handling, all these new technology, as well as we hear from hospitals or healthcare systems that the professionals do not get the sufficient training for handling it. You can also see that in schools, for example, teachers, their pupils or students are better in handling computers and IT than actually the teachers sometimes. But my question is, why is healthcare lacking all these competence when it's such an important both industry connecting to one of the most important areas in society, healthcare, when we have seen the development of IT systems working for very, very long time in the hospitality industry. You will not ask at a hotel reception to see, can I get a room here at this hotel? Well, sorry, we need to ask someone to climb all these 31 stairs to see if there is any rooms available. You would not see that. But still, we have that kind of issues happening in hospitals and wards. We need to take a amount of time to really see if there are rooms available for patients or other very, quite clear questions that could be handled in other ways. So why is healthcare lacking all these competence? I mean, we should have come more far.
Thank you. If you don't mind, I'm going to combine that question with a question I wanted to finish with, which is to ask each one of our panelists if they were to say one thing that needs to change, that can change, that would help this whole endeavour, what would it be? So that will cover competencies, I think. I'm just going to start from this side. No particular order, but from Alvaro, would you like to have a stab at that one?
Yeah.
Oh, and then William.
I mean, it's a difficult question to encapsulate the two of them, but I would say, probably you're going to say, yeah, obviously he's going to say that. To focus on the workforce. Answering your question, I would say that if we look at the amount of money that we have spent on the different parts of healthcare and the evolution over time, we would see that probably we have not invested in the places that we know that work. Like, for instance, primary care, prevention, that has not increased or has stabilized over time. And there has been major budget cuts over the last 15 years. then the complexity of the population in terms of aging population, morbidity and disease, and so forth, that has also increased. So probably where we have put the money is not the place that we should have been putting it. So I would say, like, focus on the workforce, focus on the places of the healthcare system that we know actually work, and then be careful with the implementation of technologies that we don't know if they're actually going to work.
So I think the reason we're not further ahead in the UK, at least, is our propensity for political self-harm. And the fact that we have consistently have investment in technology as a political option rather than as a long-term reality. And that's led to kind of piecemeal investment and investment in the wrong things and done in the wrong way. And then my what's the one thing we could concentrate to get things better? You won't be surprised for me to say, start with user needs.
Well, I think we need 3 words that start with the letter H in English. I think we need human centricity, I need humility, and I need honesty. So we should be human-centered, and I think that was perfectly laid out by the keynote lecture. We should have the humility for complexity. We are a hospital, not a hotel. We are a medicine, not a toy industry. If we make a mistake, somebody's gonna die. If I get in the room and there's somebody laying, that's a nice story to tell in the conference. If I have a double booking on the bed on intensive care unit, somebody's gonna die. So that's the difference. And we should be humble that this is the most complex task we have to do. And it's not comparable, with all respect to hotels or others. And the third thing should be honesty. Honesty towards the patients, but also honesty towards the staff, that this development will take decades. So I'm kind of selfish, because in 30 years, when I will be a patient, and I surely will be a patient, everybody of us will, I might benefit from some of the improvements we set and discussed today. But it won't be in 2 years, or in 5 years, or in 10 years. This is political suicide, of course, to tell something will work in 30 years and not tomorrow. But I think if we become a little bit more honest about that, that would help us. So I would say 60% now is better than 100% never, and to set a decent pace in the development to go in the right direction, step by step, would help us. So it's human centricity, humility, and honesty. Thank you.
Thank you, Reinhard. Have you copyrighted your 3 H's? Because can I use them?
You can cite them.
Okay, thank you. Marta, over to you.
I think we need to invest in training, as all we said, but not only in the health workers. We have to invest in the education, because the competence of using technologies are not in the universities, are not in the schools. But I think there is another most important thing, that is patient safety. Neither is a signature or an area which is used in the universities. So when a health worker faces to an adverse event or an issue related to patient safety, they haven't the education, the training to face. And another thing is to this training and ongoing support, because the adoption of new technology were limited. We need focus on people, both healthcare professionals and patients, because they are who use the digital tools.
Thank you, Marta. So, starting by trying to answer Pernilla, I think my assumption here is that by being in such a highly regulated industry, that has also a mindset impact throughout the years. So everything becomes harder to do because it's, for the right reasons, is a highly regulated market, but there is also a mindset impact. That would be, for your question, stop throwing money at the wrong things. It's not a question of investment or more investment, is investing it in the right places.
Well, thank you. I think it's time to have a quick look at the Slido slides, isn't it, to see what the audience has had to say. So,
So I think responses are only live when you're on the slide.
Ah, I see.
You have to give people a minute to,
I haven't been properly trained.
Yeah, it wasn't intuitive.
Okay, so you can have a go now if you've got it to change those numbers.
This is fun. It's
Okay, so about... Only 4% are neutral. So strong-minded people. So 50% now think that it contributes to the fatigue of health professionals, the use of digital health applications, and 43%, 45%, and it's changing all the time. This is real time. Yeah, it is. Yeah, okay.
You start commenting and then you need to change it. So
and what's the most important first step to ensure digital innovations effectively support healthcare professionals? I believe these will be available, the results of these will be available, won't they, to everyone? And can people continue to contribute even when we... Okay, okay.
training in education.
I've learned many things today, but I didn't think this would be one of them. Okay, I'm going to just leave that open. I think it's the last set of questions, isn't it? No, there's these ones as well. And I'm conscious, Mirka, that we're all running about 15 minutes over time. But if I give people just time to do this, perhaps you would like to explain what's happening about the long-awaited coffee break.
So first of all, thank you all for excellent panel and the session and opening and welcoming speech and everything. It's really how we imagine it. This first session was just reaching our expectations. So thank you so much for your contributions. And now I have for you 2 invitations. So those will be for the afternoon workshops. You could hear one of them is the implementation challenges, so that we will be discussing what are the barriers and facilitators for implementing the digital technology. Second one will be for the Fighting Fatigue Together workshop, where we will continue talking about the fatigue and healthcare worker well-being and safety. And now I have one good and one bad news for you. So let's start with the bad one. The bad news is that we will stick to the time, so the coffee break will be short. And we will start again at 11 o'clock. So grab a coffee and be back at 11 because, and now it's the good news, because you will be deciding about the winner of our Butterfly Impact Award in patient safety for this year. So I can encourage you to be here on time because you will hear 3 best practices, 3 projects that we have selected. And then you will decide who is going to be the winner of this award for this year. So please be here back at 11 o'clock. Thank you very much.